let's talk about non-hysterectomy surgeries briefly as we get sort of towards the end here. I think when doing laparoscopy, we always say like fives are free. Like I hate putting tens in. I never use tens for any of my surgeries, 10 millimeter or larger ports, because I don't want to close fascia. I want to minimize my hernia rates. Single site you mentioned, I am not a fan. I think those 2 to 3 centimeter umbilical incisions have such a high hernia rate. If I'm morcellating, I make a mini lap fan steel at the same size and do most of my morcellation that way, because the hernia rates from a fan steel, and we're, as obstetrician gynecologists, we are and should be confident making fan and steel incisions. They're great incisions to close. I try to avoid larger incisions in the abdomen all the time because of concern for hernia and also just pain. I mean, huge umbilical incisions, patients do not like those, and they don't like their belly buttons to be messed with. When performing a colpotomy for a single site vaginal incision, what are the hernia rates? I imagine the vaginal hysterectomy closures are the same as a TVH, but for a non-hysterectomy case, and you're doing a posterior colpotomy and doing a vNOTES for adnexal surgery, what are the risks of vaginal cuff, in a sense, dehiscence, or vaginal colpotomy dehiscence or hernia rates for those surgeries?
Yeah. So for the listeners, for a hysterectomy, we make the same incision and we have the same scar, so that's it. If we're doing vNOTES for other indications, and as I said, we do it for the whole spectrum of gynae procedures, that's where we're going to need evidence to prove that it's safe, because with hysterectomy, we're reducing our number of scars or number of incisions. We're taking the abdominal incisions away and we're just keeping the vaginal incision. Now we're in adnexal or myomas or whatever. We're taking the abdominal incision away, but we're replacing it with a different incision. And, so there's your question very correctly. Are we not taking any other risks by putting an incision in a different location? I think what we noticed is that those incisions are less painful because the innervation to the vagina is different to the abdominal wall, so there's an advantage. As far as I know, in the database, there's no dehiscences described for a posterior colpotomy. We've had hematomas from the posterior colpotomy, but no dehiscence as far as I know. I haven't had any. I think the vaginal wall's very forgiving. We know that from obstetrics as well. It heals very well and it doesn't get infected as easily. The two big questions that we always get there is, one is, what about deliveries? If we do this on young patients for ectopic pregnancy routinely. And two, what about sexual intercourse? Are we causing dyspareunia for these patients? I think the answer for the first one is it's a worry in our head, because from endometriosis, many of us are in the habit, if we've had rectovaginal endometriosis, we've shaved the rectum and we've resected part of the vaginal wall. We tell our patients, have a cesarean section and not a vaginal delivery. I think it's different in vNOTES because we don't have that rectal shaving and we just have a scar in the colpotomy. I think the data that we have on vNOTES are limited. I think there's only one publication we've made. There, it's in personal experience. We've had lots of deliveries after vNOTES and have not seen any problems. I think scientifically we have data from specimen extraction studies, people who do adnexectomies and take the specimen out through the colpotomy, and those data also suggest that incision is safe for a vaginal delivery after that. So I think that's not an issue that I worry about, and we do it on young patients. I routinely do all the ectopic pregnancies that way. And we let them deliver vaginally, and our C-section rates or our tear rates are not higher. I think that dyspareunia is a much more important question to look at. And there we need to have big data, and there's studies ongoing on that. We have data from the RCTs that we've done, or the RCT on adnexectomy, that don't show any higher problem rates. But those are small data up to now. Again, very technical, but I'm going to try and explain it anyway. I think it's really important where you place that incision. If you make your posterior colpotomy incision on the same location where you would do it for a hysterectomy, the problem then becomes that your vaginal mucosa retracts a bit. And when you close it afterwards, you don't have a lot of mucosa between the cervix and your incision to close.
Right. I imagine if you're right up next to the uterus, which is where you want to be for a hyst, you don't have much with which to close.
Exactly. And what you do then is you actually pull your uterus into the posterior fornix. You pull your uterus backwards, and then you don't have a posterior fornix anymore, which could be a cause for dyspareunia. And that's something that I think is really an important issue to teach, is to where to place that incision. So for a non-hysterectomy case, your posterior colpotomy incision must be at least 1.5, 2 centimeters lower, closer to the rectum. But then your dissection has to be upwards. And then you have a lot of space to suture. But so you need to retrain that colpotomy from people who are used to making it for hysterectomy. You need to make it in a slightly different location. And then I think from my experience, it's not a problem. I don't see any dyspareunia problems with that, but I make my incisions very low, far away from the cervix.